doing a surgery and getting some tips. So therefore, I called him to tell us how to recognize. Sometimes you may not be able to recognize also, but PCR has happened. Yes, Harbansh.
So signs indicating the PCR, first of all, we should always have a very high level of suspicion. I mean, anything which is not going according to the plan, whatever may be the step of surgery, you must suspect that there is a PCR. So in that case, like localized bright red glow, anywhere suddenly you see a bright red glow and you were not expecting, that means there's something wrong. Irregular anterior chamber depth, non-rotation or difficult rotation of the nucleus. You try to rotate, it comes back. You try to rotate, it comes back. Even if you should not attempt if it is not rotating. Even not because of PCR, because of any other reason, whether the hydro was not complete, whether the jonules are weak, whether the PC is lax. So there may be many situations where the nucleus may not rotate, but if it is not rotating, please don't force it to rotate, whether it is because of the PCR or not. The tilting of the nucleus, and people snaps and when do hydro and suddenly people gets dilated and bright red reflex. So there may be normally the way normally you do the surgery is going, everything is smoothly, you rotate, the nucleus rotates, everything is fine, it's okay, but anything you find unusual, suspect the PCR. Many times I have seen I do the hydro, I see a line behind in the posterior capsule. Then I think whether it's a PCR. And then I found out that it was because of the very lax posterior capsule, because of the lax jonules, the posterior capsule was floppy, so I can see it was a fold on the posterior capsule. It was actually not a PCR. But I took all the precautions as if it is a PCR. So anytime you have got any doubt that the chamber has become unusually deep, chamber has become unusually shallow, chamber is irregular, people gets dilated, people gets small. So something happening unusual, you should always have a high level of suspicion in your mind that there is something is wrong. And you can confirm if it is possible, rhexis margin tear extension, which they call as a flutter sign, whether it's true or not, and how much it is true that if the anterior rhexis margin gets extended to the posterior capsule, then the anterior capsule flaps will not be moving. But if it is only up to the anterior capsule, then they will keep on moving the anterior flaps. So that is called a flutter sign. Sweeping up iris fossa to look for the vitreous. Vitreous has got a tendency to come towards the incision. So that means if you go from the other side and put on a iris fossa close to the incision, try to sweep into the center, so you will see the tag of vitreous coming if it is there. So this you can do when you want to confirm the PCR. Also when you are doing a vitrectomy, you are not so sure that you have done a complete vitrectomy and before you put on a tricot, because vitreous in the AC is not as dangerous as vitreous in the wound. So there should be no vitreous left in the incision. So you sweep it and bring it in. And tricot staining is, of course, you should do a diluted tricot staining, 1:4 or 1:2, not the full tricot staining. And there is a halo test. I don't know, halo test is when you press the posterior capsule with a rounded depositor, you can see a light of halo coming from there. So the important thing in this halo test is that you should not put a lot of viscoelastic, because if the capsule is concave, you will not get a halo test. But if capsule is convex, then you press in the center, so then you will see the rim. So that means chamber has to be shallow to elicit the halo test. Otherwise, if the chamber is deep, you will not be able to elicit it. So the PCR may be visible, very clear, you have got no doubts about it. Now, like in this case, and suddenly you will see that the capsule has come, and so there is no confusion about it that the PCR is there. So there is absolutely, you know how to manage it. And the biggest mistake in attempt, we try to pressurize the anterior chamber, and because of the too much of injecting the viscoelastic, the capsule gets extended as in this case. So you don't have to really pressurize, you just have to cover the coat and do not try to put too much of viscoelastic. Whenever there is a PCR, you try to put too much of viscoelastic, and if you can use the viscoat, that will be better. So in this case, then we bring, first thing is that you bring the nucleus out of the capsular fornices and place into the anterior chamber. Because if it is in the anterior chamber, it will not fall back. If it is the capsular fornices, if the PCR gets enlarged, it will fall back. And once it comes to the anterior chamber, now you can relax and plan what you want to do. So in this case, and whether you want to do the vitrectomy with the tricot, you want to put an IOL, so whatever may be your mode of management, but first you must ensure that vitreous is out of the bag. So we enlarge the incision, then with the true instrument we try to do the chopper stick technique, try to crush and take it out, but then we thought it was not coming, got crushed. We what we call as a lens scaffold. Then you put the lens inside, and then after insuring it, if you don't want to, you are not so sure, if you want to just pull it out by your this thing, and after that you can do the vitrectomy afterwards also. So if it is possible, if you are, and finally once you put the lens, you constrict the pupil, and now see with the tricot whether. So many times it may not be visible that PCR has taken place. So then in that case, you may have a doubt whether it's there or not. So you can see the red reflex over there, and iris has started coming, but now the red reflex moves. As you move, so you think maybe it is purely epinuclear plate and the capsule is intact. So there's a little difficulty in rotation, but you can see that red reflex is moving along with. So surgeon has got some doubt that there's something is wrong. He's a little reluctant, you can see, in removing it, because he is not very sure whether the PCR is there or not. But you can see that the pupil has started constricting, and you can see now that there is a PCR. So he was not so sure and didn't take due precaution, and this rent now gets enlarged. A due precaution at that stage would have probably, and this patient had a multifocal IOL in one eye, and this eye has got a monofocal IOL. So I'm planning to now exchange the monofocal IOL with the multifocal IOL. And now this is the PCR, which was very small, has got enlarged because surgeon was not so sure and didn't recognize on time. On the other hand, in this case, same situation, and this is now happening more in a soft category where suddenly gets stuck. And as soon as we do, you can see the slight red reflex, a punch out over area over there, and whether there is a PCR or not, but you can see at the top of the screen, you can see the red area which is shining through and round spot over there. And this was a patient who had a cataract with small pupil, put on a Malvin ring. So I cover this, rotate it, and you can see the punch out area rotates. But I was sure that there is a PCR. So we removed this, and you can see that the PCR, covered it again with this. Now I lifted that, the hole I created, I lifted that, and I'm not going into the area where the PCR is. I'm far away from the area where there could be potential vitreous. So just opposite, I have removed part of the epinucleus. Now my aim is to protect this vitreous, and I put on a viscoelastic behind. So lift the epinucleus. And after lifting the epinucleus, I'll put on a viscoelastic to push if there is a vitreous behind. And now you can see that this viscoelastic is going and will push the vitreous into the periphery. And I'll avoid any maneuver, any suction, anything on that corner. Ultimately, after removal, and we could safely put the synergy multifocal IOL in this patient. So high level of suspicion is very important. Anything unusual, you should take care. Thank you.
So, Harbansh, very useful videos, but two questions, although I'm not a cataract person, but the second last video you showed where epinucleus was being removed, although PCR was there. I would have shifted this to all these machines of vitrectomy have, IA cutter. So you can, do that instead of allowing the vitreous to mix with the.
No, see, the problem with the IA cutter is epinucleus plate is very difficult to cut with the IA cutter and takes very long. But cortical fibers you can hold and suck it, but epinuclear plate is very difficult to hold with anything, even with the phaco probe. And in this case, because if at all any vitreous was there, it was absolute and to the one corner. Another corner was absolutely free. And you have got to ensure that the vitreous has got a tendency to come towards the incision. If the vitreous has not come on that side, if you can do a lot of maneuvers on the side where the vitreous is not there. So we lifted the epinuclear plate and pushed the viscoat which will stay behind the epinuclear plate. And even if there is a vitreous, some vitreous was there, it will push it into the extreme periphery. So on a low phaco emulsification parameter of a vacuum setting up 200 or 300, because now the epinucleus was already loose and has come onto the anterior part. So we did a whole of the suction, and on the other side where could have been potential vitreous.
And second question was in the presence of PCR multifocal IOL.
So that depends upon the size of the PCR. So in this, there was no chance of loop going into that stage. So no IOL, no loop was into that PCR. And if, we tried with doing little bit of vitrectomy over there, but there was hardly any. There was some vitreous tag over there. We stained with the tricot. And because the primary talk was on recognition, so I didn't show that. But there was a small tag of vitreous. After putting the lens, we actually used the cutter and constricted the pupil. So it was fine. And patient has 6/6 vision. So a small PCR. And you can put them in a toric area placed in patients of PCR. And if you have got a doubt, you can do what we call as a reverse optic capture. That means you can put the loop into the bag and take out the optics out of the bag. So that way, you can really seal perfectly all right, because the single piece lenses are not supposed to be placed into the sulcus because of the iris chapping, because the iris keeps on constricting can cause more inflammation, but they can be placed in the bag and optic can be brought into the
Okay, very useful tips. Anybody would like to differ or any questions from Dr. Harbansh before we ask Rajesh Sinha to here? So, Dr. Rajesh Sinha, Professor of Ophthalmology in RP Center, manages cornea and cataract refractive surgery. So, corneal ulcer is not an infrequent problem, frequently mismanaged. So, Rajesh will tell us about the tips of management of corneal ulcer. Because as of today, I think no corneal ulcer should be allowed to perforate or, lead into issues unless you mismanage. Rajesh?
Sir. Well, at the outset, I would like to thank Rajit Verma sir for having me in this interesting session that is on tips. And this is the term that has been coined by sir only. And I don't know whether it was discussed, but what tips means, tips in practice. So the basic idea is that we don't have to discuss too much of theory. We have to think about what are the practical tips that we take from this discussion, and we would like to have your inputs as well. So the first thing is that, when you are getting a case of infectious keratitis or a microbial keratitis, so any infection, whether it's in the chest or it's in it's anywhere in the body, the most important thing is that you identify the organism. And it's the same case